Firstly, welcome, ladies and gentlemen. Congratulations on sticking with the full course. I admire your perseverance. Anyway, it's cervical sagittal deformity this afternoon, and we've got some great speakers. We're going to start with the pediatric aspect, and those of you that deal with children will appreciate that, although uncommon, the early proper management of this problem is vital, and directing it to the appropriate specialist is key to getting good results. So we'll be starting off with my friend and colleague, Girish Solanki, who's a pediatric neurosurgeon at Birmingham Children's Hospital. He reminded me that we operated together 20 years ago, but he's gone on to become training program director and also a member of the neurosurgery SAC. So he brings a wealth of experience to it. And if you Google some of his feedback on the internet, you'll know that he gets great results and his patients love him. Girish, please.
Thank you, Mike. Thank you to the organizing committee. I'm privileged to be here to talk about pediatric deformity, which I think it's pretty much within your sphere of endeavors. But as neurosurgeons, we probably have a small contribution to give. And of course, these days, everything is multidisciplinary, so I'm very pleased to say that my esteemed spinal colleague, Adrian Gardner, who's sitting here, has been part and parcel of what I'm going to talk about today. And of course, a very large team of neuroanesthetists, intraoperative neuromonitoring, and the physios and everything else that goes with it to make surgery successful. So no specific conflicts of interest. And I think I'll start by saying that pediatric deformity is very different from adult deformity in the sense that we end up dealing mostly with congenital craniovertebral junction anomalies, while in adults it's many trauma, inflammatory, degenerative conditions. In children, of course, it's complex congenital anomalies, metabolic disorders, and you'll see in the presentation today how diverse the spectrum of disease can be in children. And of course, these anomalies go hand in hand with soft tissue changes as well, such as Chiari, syringomyelia, difficulty swallowing, difficulty breathing, apneas. So to get a child like this to theater is a daunting problem and requires a multidisciplinary approach right from the outset before you touch the patient. I thought that I would bring you the experience of our first 50 cases. We're nearly 100 now on pure C1, C2 surgery. But I thought we would probably discuss lessons learned and the common pathologies and so on. And as you can see here, these are the sort of conditions that we'll end up facing rather than just sorting out degenerative joint disease. So a little bit about embryology, and although the slides look very busy, you'll be pleased to know that the only thing that you need to know is that the vast majority of craniocervical junction anomalies comes from the pro-atlas and inferior part of the posterior arch of atlas, which is occipital somite 4 and cervical somite first. So those two pretty much account for 98% of all the congenital anomalies that we're going to see. And what are these congenital lesions then? So if we start from the occiput and atlas, the commonest one that I face in my practice is a simulation of atlas. So fusion of C0, C1 joint, sometimes unilateral, sometimes bilateral. It could be the anterior arch of C1 fused to the clivus. So what that does is stops the C0, C1 motion, and that's the flexion motion. So if that's stopped, you still have to do the flexion motion, but what it does, it moves the motion to the next segment, which is C1, C2, and C1, C2, the motion, as you know, is a no motion, and what it does, it loosens the cruciate ligament and leads to instability by doing that. Then, of course, you have the pro-atlas homeotic transformation, which Professor Pang and others elucidated, and in this particular situation, we work on a clock, so our development is on a clock, and the clivus, which is the tip of the clivus, is the fourth occipital somite, does not develop on time. So the clivus becomes short and stubby, and the fourth occipital somite then becomes incorporated on the pro-atlas, and the odontoid becomes elongated. So these conditions are often associated with the dorsal bending of the odontoid and compression of the ventral brainstem. And then you got those conditions where you get odontoid dysplasia, hypoplasia, where the odontoid may actually be missing, or there may be orthodontoidium, or there may be a hypoplasia of C1 or C2. In those conditions, what happens is now you have horizontal instability because the cruciate ligament is no longer able to hold C1, C2 together, and those conditions then will require fixation. And then there is a whole range of fusion anomalies, segmental, multisegmental, Klippel file, of course, Noonan syndrome are the commonest ones that we see in children, and extreme short neck, low hairline. So these conditions, of course, then lead to compressive lesions of the cord as well. And then I just want to clarify something about, we always talk about basilar invagination. But actually, there are two specific areas here. One is basilar invagination, and the other one is basilar impression. And they're very different. The definition of basilar invagination is pretty much based on Chamberlain's line. So if you go above Chamberlain's line, which is a line from the hard palate to the opistheon, if the tip of the odontoid is more than 4 millimeters above, then you're probably developing basilar invagination. The other way to look at it is on the coronal view. If you have the bimastoid, if you draw a line across the mastoid tips, that line should go at the C0, C1 joint. However, in basilar invagination, that line usually is at C1, C2, or even below, and that means basilar invagination. Now, okay, here we go. So in invagination, the problem is actually in the spine. So you have something like assimilation of atlas, or the lateral mass of C1 is hypoplastic, and as a result of that, C2 will move up. In the case, my slides seem to be stuck. Okay, I'm probably not pointing in the right direction. So as you can see on the image here, the tip of the odontoid is now well inside the skull. The bimastoid line is below C2, nearly at C2, C3. So this is a typical case of a bony basilar invagination related to anomaly of the spine. Then you have the situation where you have impression, so basilar impression. In this case, you're talking about conditions that involve bony fragility, osteogenesis imperfecta, rickets, Hatch-Cheney disease, spondyloepiphyseal dysplasia. In these conditions, the skull is abnormally soft, and the weight of the skull pushes down by gravity, and what happens is the center of the base of the skull starts enfolding and starts sliding down like a lollipop on a stick. And this is what we call basilar impression. So it's quite different. Management is somewhat similar, but just wanted to clarify the difference between invagination and impression. And you can see the enfolding on the red lines there. And then one of the large groups of patients that we treat in children, and again, this is a specialized area of practice, is conditions of children with mucopolysaccharidosis, particularly type 1, type 2, type 4, type 6. These children have spinal manifestations which are quite severe, lead to spinal cord compression at multiple levels, cranial-cervical junction, cervical-thoracic junction, thoracolumbar junction, and then intervention is often necessary to avoid progression of this condition. This is an example of a child with MPS 4, Morchio. You can see the bones are very dysplastic. They typically have a bullet-shaped appearance. You can see all of the bullets in the neck there. So it's very typical. Once you see it, you won't forget it. And these bones are small, diminutive. The enzyme deficiency prevents cartilage from becoming bone. So these bones are like cardboard. It's extremely difficult to operate on them. And then, as you can see, the discs are bigger than the bones themselves. And the discs often cause bulges, which cause further compression and deposition of the glucosaminoglycans along the dorsal aspect of the vertebra. So all of that reduces the space available. They invariably, pretty much every one of the MPS 4s will develop atlantoaxial instability, and therefore they will need surgery. This is another condition that is only very recently come to attention, Walcott-Rallison syndrome. So this is a congenital diabetes in consanguinity associated with liver dysfunction. That's sort of thing that we're not normally going to see. But these children have epiphyseal dysplasia. And several children then were referred to me with orthodontoidium, which I was not aware of. And I checked the literature and found out that it was not reported. And then in collaboration with Professor Nick Thomas at King's College, he also had similar cases. So we then reported for the first time the prevalence of osteoodontoidium, which is nearly universal in children with Alport-Robinson syndrome, and they often present with spinal cord compression and require treatment as well. So craniocervical disease progression, we often talk about compression, instability, deformity, but in fact, in my practice, what happens is they're all combined. Once you get instability, you're going to start getting deformity, and vice versa. So I think we should stop thinking of these conditions as in isolation, but more as the effects of the conditions underlying it. So, for example, look at this, spinal deformity in MPS. If you look at the slide on the left-hand side, that's pretty much a normal child, but this child already has MPS. But as time goes by, you can see that there is beginning of effacement of the CSF, so we're talking about compression, and very soon the effacement combines with deformity. So you can see the abnormal shape of the cervical spine, and then compressive elements, which then result in changes in spinal cord. So the trick here is to try and operate on these children when they're still well, and when there isn't a lot of malalignment, when there isn't a lot of compression, and definitely not spinal cord injury. And the same applies to the rest of the spine. So if you look at this is a sequential image over probably about 7 to 8 years of this child, and you can see the changes in the spinal cord and the spine shape itself from a lovely S shape to becoming nearly right-angled in the midline with particular compressions at the cervicothoracic thoracolumbar junction. So these children often end up having thoracolumbar surgery, definitely craniocervical junction surgery, but more and more we are seeing problems at the cervicothoracic junction as well. And a child with advanced morchio is somebody that has got macroglossia, a short neck or no neck, a pectus carinatum, and surgery in these children, it's life-threatening for them and life-harrowing for you. So that's why preparation will lead you to success. And we don't do any of these cases now without monitoring. At the Children's Hospital, we've been working for the last probably 10 years now, where we have developed this alarm criteria, where if you see a reduction in the SSEPs by more than 50%, reduction in MEPs by more than 80%, or absent brainstem evoked potentials, we get an automatic alarm and we stop surgery. So before everything disappears, it gives us time to reverse before complete loss of potentials. And we've just published a series of patients where this alarm criteria helped us protect children from developing complete neurological deficits in something like 80% of those children. If we had progressed without listening to the alarm criteria, there was a good chance that they might have developed some sort of neurological injury. Then when we look at the whole series, so this is, as I mentioned, the first 50 cases, about more than 50% of our cases are metabolic cases, and that's the big brackets there. But then there is this whole range of children with problems which can be related to instability. And as I mentioned, when I looked at the same patients, they also had compression and deformity. So I think this kind of the categorization of patients is not helpful, and we should think of all of them as needing correction of deformity, needing decompression, and needing stabilization. And of course, when you do surgery like this, it's inevitable that you're going to get complications, and auditing them and learning from them is critically important to avoid making the same mistakes in the future. In our series, we had about 2% of permanent deficits in children in the first 50 cases. CSF leaks, about 2% as well. Pin site perforation, because most of these children were going to have halos as well. And about just under 4% of transient weakness, the children who developed immediate weakness but recovered before discharge. And the commonest complication actually was wound breakdown, because these children are poorly nourished and require significant support. So wound breakdown is a problem for us. So I just wanted to illustrate a few cases that we faced. So this is the child that I'd shown you before, a child with MPS 4 who had thoracolumbar and craniocervical junction compression and signal change. When you look at the CT scan, you can see the significant C1, C2 subluxation on this child with evidence of cord compression on the MRI scan. So these children normally would undergo what I would call a Goel-Harms technique, where we would put C1 lateral mass screws and C2 sort of a laminar facet screw wherever we can get the screws on these children, and then correct the alignment by tightening the tulip screws, and occasionally in some children where we can't get good purchase, we would extend the C1, C2 fixation to the occiput or to C3. You can see on the pre and post the extent of correction by just getting the alignment. The bones are very soft, but there is quite significant instability, so it's not difficult to correct them as long as the lateral masses haven't fallen forward, and you don't have to do a lot of work on that. In some children, because the problem with Morchio is that they don't have any osteoinductive ability because of the enzymatic block. So it doesn't matter what you do, you get your fibular bone, or you get your rib bone, or you get your skull bone, they don't often fuse. So in those cases, I attempted to use BMP2 posteriorly, and I have to say the fusion rates are exceedingly good. But of course, due to this was before all the problems with BMP started, so we pretty much have stopped using it. But our experience was pretty good. So this is an example of the odontoid hypoplasia in MPS 4, as you can see on the slide on the right-hand side. And after fusion, after fixation, we were very interested to see that the odontoid had developed, which suggests to us that the odontoid hypoplasia, which is supposed to be part of the syndrome of MPS 4, is likely not part of the syndrome, but likely because of microconcussive trauma during the subluxation. And once the fusion was performed, there was no longer trauma, and the odontoid was able to redevelop. So that's something that others have also talked about. Children with halos tolerate them really well. The parents suffer enormously, but the kids actually, love the halos, and they show off. So it's not a problem. Just want to tell you about another case. This is now craniovertebral junction with platybasia, basilar invagination, dolichoid dens, atlas assimilation, with ventral brainstem compression Chiari. So this is like the whole, 9 yards. This particular child that presented with apneas, falling behind in school, then became ataxic, and by the time I saw her, she was already myelopathic. This child also had as an underlying syndrome, which is Cruzon syndrome, for which the child had previously undergone craniofacial surgery. So here's the MRI scan showing significant atlantoaxial subluxation, and the odontoid tip is now inside the skull. But on the CT scan, you can see that the basilar invagination is associated with the typical malalignment of the facets. So if you look at the C1, C2 joint, that joint is supposed to be horizontal. But in basilar invagination, inevitably, the C1, C2 joints become more and more oblique to allow C2 to slide in between the lateral masses of C1. And surgery on those patients is extremely difficult because you can't put a C1 screw as C2 is getting on your way. So the first thing that we often have to do is to carry out a full exposure C1, C2 joint from behind and drill, as you can see there on the right side, the left C1, C2 joint is actually osteosclerotic now. It's pretty much fused to each other. And then during surgery, we use a diamond drill to try and mobilize that joint. Otherwise, we would not be able to distract. And once that's done, then we would be able to move C1, C2 away from each other. And you can see the result of the distraction. And in these cases, when there is a simulation of atlas, I use an occipital-cervical technique rather than C1, C2 technique because the atlas is already assimilated, so there isn't much advantage in not doing an occipital-cervical fixation. So as you can see, this is the pre-op and post-op. You can see the anterior arch of atlas is now fused to the tip of the clivus. The odontoid was about 6.5 millimeters inside the skull, and then following distraction, the odontoid was brought down satisfactorily. The other large group of patients that we have to treat in the current cervical junction and cervical spine is deformity, particularly because of neurofibromatosis. So we often have children presenting with cervical kyphosis, which sometimes progress very rapidly. And this is one particular child where this happened. You can see on the CT scan quite a ghastly appearance of a very elongated C2, and then 3, 4, 5, 6 are actually bundled and basically crumpled upon each other, causing, and posteriorly you can see the expansion, so the facets are no longer connected to each other. There's significant loss of facetal contact and instability. And when you look at the MRI scan, quite a severe compression of the spinal cord from anterior. The child was myelopathic with brisk reflexes, fortunately non-sustained clonus. She went immediately on a halo, distraction, and then following consultation with a number of, this is not the sort of thing that I see every day, so when you get one of those, you call everybody that you can, including your mother, because you want to get the best possible advice on this. And of course, with the help of my colleagues at the Royal Orthopedic Hospital and others, we then etched the plan. So as you can see here, there's hardly any bone in the back as well. In a way, this was actually good for us because the compression was less, but it made it extremely difficult to actually target where you're going to treat them. So the majority of the advice was that we should go from the front and do some vertebrectomies and do a fixation from the front. But in this case, we would lose something like 3 or 4 vertebrae in that process. And it just didn't come, we didn't feel that that was probably the best way to do this. So we maintained traction for as long as we could. And then we decided to see whether we could try and distract by releasing, by drilling some of the facets which were already poorly developed, creating some space in the pedicles, wedging them, and see whether by doing like a partial wedge osteotomy, we would be able to then extend the neck. So I won't bore you with the details of the procedure, but here's the pre-op and post-op following the initial posterior approach. And you can see that we were able to, under intraoperative traction, and then drilling the pedicles, getting space in the back, allowed us to then straighten the spine as much as we could. Now we could actually see the vertebra on top of each other rather than overlapping each other. And having done that, we were then able to successfully operate from the front and fusor from the front as well. The bones were so thin that the normal 2-screw plates were not possible, and Adrian and myself had to use a single flat plate with single screws all the way from C2 to C7. Fortunately, in this case, she did really well, although immediately she had some C5 brachialgia, which often happens with forced extension in these children, but she recovered from that. Not long after, we had another child that presented again with cervical kyphotic deformity, NF1, and this child actually had quite severe, not just cervical kyphosis, but scoliotic deformity as well. And so this was a 2-stage procedure that Adrian and myself did, correcting the cervical kyphosis first, aligning it, keeping on a halo, and then coming back and performing a cervical deformity correction at the cervical thoracic junction. And these are the sort of the outcome of that. And I think more and more, as we work together, we are able to do this sort of work. Now, one of the things that we often find is that with platybasal and basilar invagination, we find that these children have Chiari malformations. And there's been a lot of discussions about how to properly treat patients who present with Chiari malformations. And one of the standard treatments in neurosurgery is to carry out a foramen magnum decompression. But if you do that in somebody with basilar invagination, the basilar invagination will worsen, and the child will become more unstable. So other spinal surgeons have now started doing distraction surgery which involves moving C2 out, just like you saw in the previous case, and fixing them, and then evaluating the progress of the Chiari. And we've now got about 12 cases where we have done exactly that with improvement, spontaneous improvement of the hindbrain hernia. So this is one of the cases. This child, very young, initially she was symptomatic from neck pains, but really didn't have anything that we could operate on. But then very quickly, over a period of 3 years, developed malalignment of the joints, as you can see here, and worsening basilar invagination. So at that point, carried out the C1-C2 distraction and fixation. Subsequent to this, you can see how the hindbrain hernia spontaneously regressed without any surgery to the hindbrain hernia. So I think fixation does provide the space for the CSF to flow adequately enough for the hindbrain hernia then to resolve itself. So something to keep in mind. This child, unfortunately, had a complication and resulted in a rod fracture. And then as a result of that, we then went back, and I suspect that one of the rods rotated, and then all the tension went on the other rod. The rod fractured, and we went and changed both rods, and she's fine. One other issue that we often find is that children who present, so this child actually had the initial diagnosis of achondroplasia, which was then postnatally corrected to pseudoachondroplasia, and presented with this very typical evidence of what looked like a cystic ganglion dorsal to C2. So this is what we call the retroodontoid masses. We used to see a lot of those when rheumatoid arthritis was in full flare. Now, of course, we hardly see anybody with rheumatoid arthritis developing this sort of problems. But this child clearly had instability. On this image, you can't see very well, but on the CT scan, you'll be able to see that this child had osteodontoidium. And the movement was creating formation of this ganglionic cystic retroodontoid mass. So a very quick word on pseudoachondroplasia. It's very different from achondroplasia. In fact, the achondroplasia is a gain of function mutation of the FGFR3. Pseudoachondroplasia actually is a mutation in the cartilage oligomeric matrix protein, which is a comp gene. Although they are both dwarfs, they have very similar appearance, the facial features are different. And children with pseudoachondroplasia develop arthritis. Children with achondroplasia, on the contrary, they have really strong bones and they won't have any instability, but pseudoachondroplasia develops instability. So when you look at these two, it's critically important to make the right diagnosis, because initially they both look like could be achondroplasia, but in pseudoachondroplasia, you'll end up having atlantoaxial instability and cervicomedullary compromise. In achondroplasia, you get spinal canal stenosis and cervicomedullary compromise. So it's important to separate them, because in one, you have to fix, and the other one, you have to decompress. So this particular child presented, as you can see now on the CT scan, there's evidence of the osteodontoidium, and then we carried out the C1, C2 fixation on this child. This is the postoperative image. And then sequentially, I was pleased to see that the retroodontoid mass disappeared without any intervention. So again, fixation often deals with a lot of these other secondary pathologies, and you don't have to intervene in them. And then over a period of several years, the signal change also disappeared in this child. So this is all very positive. And then I looked at the literature about retroodontoid masses, and I found that Professor Goel had a series of 53 patients, and he also reported that he did not operate on them, and that they resolved either spontaneously, completely, or partially. So I think this is something for us to keep in mind, that surgery for retroodontoid masses is not necessary. Now, these are other conditions that we often see. This child is also being referred to me as a child with achondroplasia, but I suspect that this is probably pseudoachondroplasia, looking at the appearance of the C2. Other conditions that we often have to treat, osteogenesis imperfecta. This is the sort of condition that really gives you nightmares, because the bones are very fragile, they break. Putting screws on them is not always possible. And you can see the significant malalignment in these children, because they just don't have the ability to maintain a good sort of alignment. But somehow it is possible to operate on these children as well with care and the treatment, preoperative treatment for strengthening the bone density is critically important in these children. This is a child that presented to me with an unknown skeletal dysplasia. This is a refugee, so they went through this refugee pathway, as a result of that, they came to us quite late. So this child has got severe dysphonia, orthodontoideum, basilar impression, and when you look at the scan, you can see that the orthodontoideum is separate from C2, is inside the skull. And you have to really wonder, how is that, even if I try to distract, the odontoid, the tip that is separate might not come down. But fortunately, during our C1 occipital-cervical distraction, we were able to distract all of it and carry out the fixation. This is the images of that. Just for the sake of brevity, I'm going to jump and conclude now. So craniocervical junction deformity, one large group of patients that we deal with is those with basilar invagination. If you have a simulation of atlas, I think it's reasonable for you to do an occipital-cervical distraction and fixation. If there's no simulation of atlas or the simulation is unilateral, then you may consider doing a C1, C2 distraction and fixation to preserve motion at the C0, C1 joint. And that often is associated with improved swallowing in these children. And very rarely, I've not done a transoral now in nearly 20 years. You may be forced to do a transoral approach, odontoidectomy and then occipital-cervical fixation. The other group of children we have is the children with orthodontoideum, either from Down syndrome or pseudochondroplasia or any other condition, the C1, C2 subluxations, horizontal or rotatory, and then the children with the mucopolysaccharidosis, they often can do with a simple C1, C2 fixation without any need for any distraction. And then finally, in those children where the compression is also extend to the subaxial region, you've got to do an augmentation laminoplasty on those. And then children who have inflammatory, erosive, arthritis, fragility disorders, osteogenesis imperfecta, NF1, they often present with kyphotic deformities, and they often need both anterior and posterior surgery, depending on the, the extent of the disease. And then the children with achondroplasia and other conditions like that may require decompressive surgery. So just to finalize now, congenital metabolic conditions, there are absolute challenges to surgery. We shouldn't get into them without having a strong multidisciplinary support team that can look after all of the comorbidities before you, put knife to skin. I think it's pretty much in this day and age, a mandatory MDT. We do a monthly MDT for all of our spinal metabolic conditions, anesthetic assessment, respiratory, ENT, consider whether tracheostomy is warranted, detailed surgical pre-planning. So all of that leads to success in these operations. The anesthetists are usually very clued in. We have got intraoperative monitoring, and all decisions are made in consensus so that there is no arguments afterwards. So there are other things that, with more time we would be able to discuss, but just to let you know, in children, we tend to operate on this sort of children, this sort of patients rather than the trauma and the degenerative conditions. And I really want to thank you for your patience listening to me. Okay.
Thank you, Girish, for a really great exposition on a very sort of complex area. So, ladies and gentlemen, we're going to have a very big change in scene now. And many of you will no doubt have noticed when you're walking around town at weekends the increasing prevalence of cervical sagittal deformities. And this session really goes to address that. So we have a really interesting session about what is cervical sagittal deformity, why is it important, and how you treat it. So we have two speakers. I'll introduce initially Lennon Lutchman, who's, I'm amazed to read these now in his 17th year of being a consultant at Norfolk and Norwich Hospital, as well as being an examiner for the FRCS Orth. He's also the education lead for BAS. But also we have a virtual speaker, and we're very fortunate to have contribution from Professor Chris Ames, who's the Director of Spinal Deformity and Spine Tumor Surgery at UCSF. before coming here, I went on PubMed to see how many publications he's got. It's over 670 on a very wide range of topics, including adult deformity, cervical deformity, and latterly, machine learning and AI. So a very sort of talented man. And he's also the winner, exceptional performance of the very prestigious HIBS Award awarded by the SRS meeting every year. So without further ado, can we just put on Professor Ames' first talk, please, and we'll run through that, and then we'll bring on Lenel to follow. Thank you. Are you able to? Thank you.
Hi, I'm Christopher Ames, and it's a pleasure to be with you at BritSpine 2023, and I really appreciate the invitation. I'm very honored to be asked to speak with you. I'm going to be discussing our cervical deformity classification in the first lecture, and then I'll have a two-follow lecture about surgical planning and osteotomy in the cervical spine. My disclosures, my only significant disclosure is that I do receive a royalty from DePuy Synthes for their Symphony system. When I first started in cervical deformity in the International Spine Study Group about 10 years ago, I was the only neurosurgeon in the group at that time, and they asked me to basically to try to translate what Frank Schwab had done for the thoracolumbar spine into the cervical spine, essentially to try to make sense of these various morphologies of cervical deformity, what was going on radiographically, how do we analyze different case types, and then how do we correlate really the sagittal plane to the patient's disability scores. We really have a spectrum in cervical deformity surgery, from the assessment of a moderate fixed deformity, like in this case, where there's only moderate translation of the head, and the patient's still able to obtain a horizontal gaze, to mild fixed deformity, which is even kind of more difficult in many ways, because many of these patients are rigid, have anterior head translation, and we have to ask ourselves, you know, is it worth offering a 3-column osteotomy to these types of patients? And this is what a lot of the classification work had to do with, was trying to develop the radiographic paradigms to then figure out what osteotomies needed to be performed, how much correction was necessary, to then try to make a reasonable statement about whether the morbidity and correction magnitudes were reasonable. And then we have these patients who really don't even seem like they have a very severe deformity, right? They have their external auditory canal is well positioned over their sternal notch. But when we ask these patients to relax and assume a position of comfort, we see that they were compensating really to get back to that neutral position. So there's really a broad spectrum from some of the rigid deformities I showed you earlier with kyphoscoliosis to this more mild sagittal plane deformity. And when I came into this about 10 years ago, really there was no paradigm, none of the radiographic parameters existed really to, aside from kyphosis assessment, to try to figure this out. So one of the first things we did in the International Spine Study Group was we tried to figure out how much cervical malalignment was really affecting patients, and we used the EQ5D in our database. And it was interesting, what we found was that cervical deformity was really causing very significant morbidity for these patients, really on the order of the same level of dysfunction as emphysema and even significant visual impairment. So it did seem, from a public health standpoint, studying this and treating it was probably worthwhile. Also, we took a look at what was going on in the United States in terms of the prevalence of these cases and, you know, were they increasing in volume? And we found that, yes, dramatically, essentially, cervical deformity was more rapidly increasing than in the degenerative population. And this was nearly an exponential increase over the last several years and decades. And probably one of the main drivers for this was increased appreciation, but also had to do with a lot of iatrogenic deformity. And here you can see the figure when we compared it to non-deformity cases. Deformity surgery is growing much more rapidly. That's why it's also, you know, of increased interest to the implant companies everyone's paying a lot more attention to this, both in treatment and in planning. And then the demographics of this population was also shifting over the years. We were getting older and older patients, and I'll touch on this in my second lecture as well. So I always like to really position things as a story. Many of you might remember my mentor, Volker Sonntag, who I trained with at Barrow many years ago. And when I was training with him, we were really entirely focused on segmental kyphosis. A little bit maybe of regional kyphosis, but it was mostly a segmental argument. And when there was kyphosis present, we would treat it, but we really didn't have any good paradigms as to how or why or how much correction we needed to achieve. We really didn't have any science behind it. The first science that came into this, at least in the US kind of American literature, was a study by Hardiker published in 1997, where he was the first one to show a couple things which were interesting. Number one, that overall the cervical spine is really not all that lordotic, especially in the mid-cervical segments. That's important to keep in mind when we're trying to realign the spine. And then also, very importantly, he developed this concept of the plumb line from C2 to C7 and found that it was on average about 1.5 centimeters. Furthermore, when we look at kyphosis itself, we see that really kyphosis is not, should not be considered always pathologic. 32% of patients that are asymptomatic actually have a kyphotic cervical spine. So it's not merely the correction of kyphosis, as we used to think when I was growing up in spine surgery, that was important. It's really a much more nuanced argument about what's going on with the overall balance of the head, a lot of other parameters essentially likely related to disc chemistry that we really haven't fully understood, and then functional assessments in terms of ease of assuming position of functions and position of gaze that I think are more important and coming out over the last several years and into the future now, probably more likely driving this disability score than just overall kyphosis. So, as I mentioned, this was the paradigm we had in the International Spine Study Group years ago. This was for the thoracolumbar spine. And based upon this clinical need that we'd assessed, we decided to try to develop the tools to apply this to the cervical spine. So this lecture is really a story of, where we started and how we did this. The first thing we did was try to develop an idea of what was normal cervical alignment. We knew that cervical kyphosis itself was not abnormal in every case. So what determines normal? Well, a couple things. The pelvic incidence, higher PI patients actually have more cervical lordosis, and this was a study I published with Virginie Laflage a few years ago, showing that this relationship, it's driven through a chain of correlation. Higher PI leads to more lumbar lordosis, especially in the upper lumbar segments, leads to more thoracic kyphosis, and this drives a higher T1 slope, which then leads to more cervical lordosis. This is not the whole picture, though. I didn't include slides on it in the interest of time, but there's also some inherent alignment of the clavicervical angle and the skull that has a lot to do with the upper cervical alignment, particularly. This is kind of akin to the pelvic incidence, the way the angle at which the clivus docks in the skull is also important. And then there's a concept of how the entire thoracic spine really docks into the sternum and the rib cage. It probably also makes up about 50%. But since a lot of us are deformity surgeons, we like to kind of work from the pelvis up, and this argument makes kind of the most sense to me. There's also another argument that's driving a lot of the disability scores here, and that's this cantilever argument of how far the head is cantilevered off the shoulders. The head usually weighs about 4.5 kilograms. As this moves forward, we drive disability scores. So combining all this together, I had the idea that we could build on what Hardiker had developed and essentially try to show that many patients who were not improved after surgery likely had not enough cervical lordosis, and it was due to this translational deformity, very similar to flat back, but essentially flat neck in the cervical spine, where the cervical lordosis didn't match the T1 slope and the head was too far forward. So we noticed this in our population, and then we did a pilot study. This is actually now one of the top 10 most cited papers in the Journal of Neurosurgery, published years and years ago now. And we included patients from various sites, and what we found was that the C2 plumb line, which was very easily measured, it was exactly Hardacre's plumb line to the posterior corner of C7, actually had a good correlation to cervical sagittal balance and disability scores, to the NDI in particular, but also to the SF36 score. Even though this plot doesn't look as significant, it was actually more statistically significant than the NDI plot, for example. So it was causing significant disability as well as general health impairment in the physical component scores. We then did a regression analysis and found very similar to the thoracolumbar spine that this worked out to be about 4 centimeters of positive balance in the cervical spine is essentially where the disability scores really dropped off. Had a little animation created to kind of show this picture, and you could imagine a story here where the patient's accumulating various deficits. So one would be patient develops degenerative arthritis in the lower cervical segments, the head drifts a little bit forward, then maybe undergoes a not very lordotic mid-cervical ACDF, loses a bit more lordosis there and invokes more compensation to try to get the head upright again. You can see that the malalignment between cervical lordosis and T1 slope is increasing. The head's drifting a bit farther forward. There's increased recruitment of the musculature to try to compensate for this deformity. And eventually the patient reaches a point where they can no longer compensate. Essentially, they're at full extension just to reach level gaze. This results in a lot of muscular energy expenditure, and this is driving really the cervical deformity and the disability scores through pain. So just like PILL is probably the most important parameter in the lumbar spine, we wanted to develop this relationship in the cervical spine. So we just built on that work, and we looked at the relationship of the T1 slope to the cervical lordosis. And just like I just showed you, as the cervical lordosis decreases and the T1 slope remains the same, we see the head drifting forward. And this was our second parameter that we looked at, and we found a value of about 20 degrees, 17 to 22 degrees, essentially, where after that is exceeded, there's really an increase in disability scores again. So this was our second parameter. We have C2, C7 SVA, and we have this C2 cervical lordosis parameter as well. Our work was then validated by Hanjo Kim at HSS, where he actually showed even higher R values for the correlation coefficients between the T1 slope as well as the C2 plumb line to the neck disability index. We then looked at overall relationships of T1 slope and drivers of T1 slope. And what we found was when T1 slope was greater than 32 degrees, the driver was typically in the thoracic spine. And this is a case where we then recommended that surgeons went on to get full-length film. So another take-home point maybe from this talk is when the T1 slopes over about 30 degrees, look below, the deformity is often lower down. And then one of our last parameters was a historical parameter that we still use a lot, was the chin-brow vertical angle. And everyone had talked about compromise of chin-brow vertical angle being linked to neck disability, especially in the ankylosing spondylitis cases. But really hadn't developed this parameter and associated it directly with disability scores. So Themi Protopsaltis in our group developed a surrogate for this chin-brow vertical angle, which was visible on radiographs, so we could measure it in our database. We didn't have clinical photography, and that's why we used the slope of the line of sight. And what we found was that the slope of the line of sight was well correlated to chin-brow vertical angle, and was very correlated to neck disability scores as well. And when the chin-brow vertical angle was less than -4.8 or greater than 17, the disability scores really seemed to increase. So this was kind of the sweet spot, and this is what we added into our cervical deformity classification. Here you can see different gradations of chin-brow vertical angle. Most of them that have compromise of chin-brow vertical angle have rigid or very severe deformities, obviously, because they can no longer compensate. Finally, we looked at a parameter which we didn't include in our final depiction of the classification, but we found interesting, and that was the occiput to C2 hyperlordosis. And I'll talk about this when I talk about planning in the second lecture. But essentially what we saw was that most of the patients that had cervical sagittal imbalance also had hyperlordosis of the C1, C2 region. This was correlated to pain scores, but we didn't have a high enough correlation to disability scores to include it in our final classification. Then, really lastly, we wanted to look at the relationship between myelopathy and cervical deformity. We didn't know what that relationship would be or how strong it would be, but we decided to do a collaboration with Michael Failings and AO North America, where we started to investigate this possibility as another driver of cervical disability. We looked in the literature and found there was some good support in the literature that kyphosis itself was damaging to the spinal cord, probably through an increase in intramedullary pressures and cord lengthening. This is very familiar to surgeons that do thoracic deformity, for example. Many of these patients with high deformity angular ratios are myelopathic due to spinal cord stretch, most likely. This work had also been supported by a work that Charles Kuntz had done in a cadaver showing increased intramedullary pressures. And interestingly, the intramedullary pressures were not just increased with kyphosis, but they were also increased with translational deformity. So we did this study with AO North America. We looked at relationship of the MJOA scores to C2 sagittal malalignment, and we found a weak but real correlation between sagittal imbalance and MJOA scores. That was the first time that had been demonstrated. And then finally, to depict the apex location, we developed this scheme where for apex localization, we use a relationship between the C2 slope and the T1 slope. Patients that have low C2 slope but high T1 slope, their apex is often in the upper thoracic spine or the thoracic spine. Patients that have high C2 slope and low T1 slope, these are the isolated cervical deformity patients and often can have osteotomies only in the cervical spine. And then finally, life is difficult. Many patients have mixed pictures where they have high C2 and high T1 slope. These are the patients often getting C2 to T10 surgeries, which I'll talk about in my second talk. So that's how we arrive here with the current International Spine Study Group cervical deformity classification with the apex localizers on the left and then the radiographic clinical correlated radiographic parameters on the right. So C2 slope, horizontal gaze, cervical lordosis minus T1 slope. The MGOA we brought in as well because we found that relationship with our AO North America classification. And then very importantly, all of this is placed on top of the Schwab classification because everything below affects the cervical spine. That's why cervical alignment, I think, is a bit more difficult than thoracolumbar alignment because it's all linked together essentially. And I'll just show a couple of things. We've moved into using machine learning now for our next revision of the classification. This is work that we did with Hanjo Kim and Virginie Lafage. And essentially the machine learning unsupervised clustering found three different main types. One we call flat neck, which is essentially the moderate deformity. These patients are often treated with C2 to T1 or T3 short segment constructs. The focal deformities, usually these group 2 patients are treated with anterior surgery all in the cervical spine. The group 3s are the ones that have high C2 and high T1 slope, and these patients often need more extensive reconstructions, often including the cervical thoracic junction and the thoracic apex as well. So these are cases often going from C2 to T10 currently in our practice. What are the issues we have in classification? I'll just finish with this. One is we don't have a very good instrument for cervical deformity. We're working on building an SRS-22C right now, is one of our main projects. Furthermore, we have high complication rates, as I'll talk about in my second talk. And then third, what the issues that are important for patients with mild deformity versus those with severe deformity are very different. And it may be hard to apply the same instrument when we classify mild and severe deformities. The ones we use for a mild kyphosis may be very different from what we should use for a rigid chin on chest, for example. So thank you very much for your attention, and I'm going to move on to my second talk now. And I will pause this lecture and record it.
Great. And on that note, we'll lead straight into Lenel's case, which will set the scene to some extent to some of the issues related to adult cervical deformity. Lenel.
Okay, I think this might be the second slide. There we go. So this case we've previously presented in a BSS, a BAS forum, our case of the month. And when we decided we were going to have this session, Mike asked me to present it. This is a patient looked after by my colleague Andy Cook, who's kindly given me permission to present it. Some of the discussion I've found in the last hour very, very daunting in some ways. Certainly, the cases presented by Girish are super specialized. They're not something I see. Now I know who to send them to. But this is something that we all see as spine surgeons, and you'll have this in your clinic at least once a month. So this is a 57-year-old lady who presented to our hospital with neck pain. So the age is much more an age we're familiar with. This is not a pediatric population, and neck pain is ubiquitous, and we see it in our clinic all the time. But what was really interesting about this lady's complaint is that she was referred by her GP, and not just because of the neck pain, but because it's evident that her head was tilting forward, it was falling forward. And she presented with a significant cervicothoracic deformity. And she noticed it 15 years previously, but reported to us that, look, this has gotten really bad in the last 2 years. And she was at a stage where she was struggling to maintain horizontal gaze. We see this a lot in older patients. And usually you try to be very conservative and send them away. But here we have a 57-year-old presenting with a loss of forward gaze. There's no history, no known history of inflammatory spondyloarthropathy or ankylosing spondylitis. And when you ask her, she says, when I lie down, my neck straightens out a little bit, but not a lot. The main problem I have is I can't see forward, my neck is progressively tilting forward, and my neck hurts a lot. On specific questioning, she reported some mild issues with balance, and perhaps some with her hands, mild loss of fine motor coordination, but no gross upper or lower limb neurological symptoms. So again, I hope you agree, we've brought it back down to earth a little bit. This is a patient that we all see. The only difference is she's probably a bit younger than we sometimes see. The other thing about this lady is unlike a lot of the patients we see, she was really active and healthy. She was really slim, she enjoyed yoga, and tried to be as active, and she was really invested in her own health. She started yoga in an attempt to try and stop the progressive deformity of her spine. She thought that would help. So one important thing with this lady was she was very invested in her own health. She was young and she had no significant comorbidities. Because of her neck pain, she'd been to the pain clinic and had some neck injections, which didn't really help for very much. On examination, and unfortunately I don't have any clinical photographs, I'll show you some x-rays. She had a cervicothoracic kyphotic deformity. Clinically and radiologically, she looked to have a compensatory lumbar hypolordosis. And quite significantly, I think, she had a mild incoordination of her hands and mildly and brisk upper limb reflexes. Her lower limb reflexes were normal, if not slightly exaggerated, but her planters were certainly downgoing. So maybe a suggestion of the possibility of cervical cord compression. So I'll just show you the radiology now. These are x-rays that were taken at the referring hospital, which is one of our spoke hospitals, but the flexion extension radiographs confirm, you can see there, I don't have a laser pointer, I don't think, but you can see the cervical kyphosis, which is distributed throughout the cervical spine. And Dr. Ames was telling us about cervical versus cervicothoracic, so we felt that this was a cervical-based deformity, the apex in the cervical spine. You can see a spondylolisthesis at C4-5. And you see osteophyte bars at C4, 5, 5, 6, and possibly C6, 7. And you can see that in these attempts at flexion extension, the spine does not appear to move very much. I don't have the full-length standing radiographs, and Chris Ames makes that point. It's really important to get full-length scoliosis views from head to hip, but unfortunately I don't have those. I do have a stitched image from the referring hospital. If you wanted to talk about the global balance, you'd have to extrapolate it from this image, unfortunately. You get the feeling that her head probably is not too far in front of her pelvis, and that what we're dealing with is a deformity centered in the cervical and cervicothoracic spine. In terms of further investigations, Andy arranged an X-ray with the patient lying flat over a bolster. Our impression is that this perhaps did correct a little bit, not significantly. And naturally, these patients all need full imaging. Again, if she was an elderly patient, you might be fairly minimalist. But here we have a young, active woman, very invested in her own health, very specifically complaining about loss of forward gaze and neck pain. So we threw everything at her, really. This CT scan confirms ankylosis in the mid-cervical region, but the other levels look relatively preserved. Again, that shows the bony ankylosis. And this is an MRI scan. Our interpretation of this fit, we thought, with the clinical picture. She has C3, 4 cord compression. You can convince yourself maybe there's a little bit of signal change in the cord. There's circumferential cord compression, both anterior and posterior. And we felt that what we were dealing with, therefore, was a young woman with early myelopathic features, clinically and radiologically, with a cervicothoracic deformity and loss of forward gaze. So these are the problems that we're faced with this patient. We arrange a muscle biopsy. It's not our routine practice, but if we're even remotely contemplating surgery, we make sure that these people see a neurologist. We make sure we've excluded a myopathy or neuropathy, which we did, and we arrange a DEXA scan that showed her bone quality to be reasonable. So we discussed this as MDT, as we often say, in our complex spine clinic at Norwich. All 5 spine surgeons do one clinic every few weeks where we see complex adult spine. And we also have a very active East Anglian spinal group to which we presented the patient. So I just wanted to do a bit of a straw poll now. That's the end of my case presentation. Does anybody have any questions about the patient? I think I've presented a fairly clear picture of what we're dealing with. And I just wanted to ask, I might just flick back to the MRI. Everything taken as it is, who, by a show of hands, would simply, I say simply, it might not be simple, who would do an isolated decompression of the cervical spinal cord at C3-4, either anteriorly or posteriorly or circumferentially, your choice? Who would do an isolated decompression on this young woman with early cervical myelopathy and with some cord signal change? It would not be an unreasonable option. Show of hands, please. Just decompress. Yeah. That seems very reasonable. The issue that we had with her is we put that to her. And we talked a lot about facilitated decision-making, didn't we? And unfortunately, this woman could not be facilitated out of wanting to have a straighter neck. She felt very disabled by her inability to look straight ahead. And if you see these people in your clinic and in life, really, it's a really disabling, debilitating condition. And you know, imagine being 57 years old or whatever, and having a neck that looked like that, and you can't look forward. We were very careful to say that our priority was to try to decompress the cord. We felt that that was something that was likely to be beneficial. We talked about the possibility of realigning the spine, but we were always very careful to say we're not optimistic about being able to help your neck pain, which obviously was the second major problem that she had. So who would entertain decompression and realignment surgery, either anterior, posterior, or circumferential? So Alex would. Yeah, I think the majority of us in the surgical community would entertain it, mainly because she seems to be a deserving patient. I don't mean that in a sort of patronizing way. She's invested in her own health, and she's quite clear about what is causing her problems. And if we feel that we can execute a safe correction and decompression, I think I would agree with you all that she's an appropriate candidate.
Thank you very much, Len. That's what a great scene setter. And with that, we're going to get down to quite literally the nuts and bolts and the technicalities of how we solve anterior cervical deformity. So if we can have Professor Ames's next talk, and if at the end of that, I'll ask you if he's online, please. Okay. Thank you.
Hi, Christopher Ames again, and pleasure to be with you for my second lecture. I'm going to talk about some of the things I've learned in 150 three-column osteotomies of the cervical thoracic junction. And I'll try to cut out a little bit of this talk to make up some time. I think I ran over in the other lecture. My disclosures remain the same, and I always like to tell it in the context of a story, as you know. So I started out doing this as an attending surgeon in 2002. This is one of my first cervical thoracic osteotomy cases. It was an ankylosing spondylitis case, and I did this in 2 stages. I was just working by myself and did an opening wedge osteotomy, standard procedure at C7, and then we had to do a vertebral column resection in mid-thoracic to get this fully corrected, all staged about 8 weeks apart. Patient had to come back to surgery. Here you can see the 2 osteotomies there. This was one of my more recent cases in 2022. This is kind of our standard now. We use 2 surgeons. We do these surgeries in 1 day, even if they require multiple osteotomies. This was single stage, over 100-degree curve, and did opening wedge and PSO all in the same day for the correction, same surgery in about 4 hours. So this is the power of experience and learning that 2 attending surgeons are better than 1, and also just gaining some personal experience. So a few tips on planning. Number 1, what we always try to do a posterior column osteotomy versus a PSO when we can. I'll show you why that is in the some of my experience and complication slides. And we plan for what we call relaxed compensation, and for that we use the position of comfort, like I showed you in my earlier talk. Essentially what we do is we have the patient fully relaxed, and we say, okay, this is your standing posture, now assume a relaxed position. And often what we see here is the patient relaxes the occiput to C2 region. But furthermore, what it does is it uncovers the greater magnitude of the deformity. This is exactly the same as saying stand with a relaxed pelvis or with your knees straight, kind of removing the compensation so you can uncover the exact magnitude of the deformity. You can do this also in some of the planning software, but the easiest thing to do is just have the patient relax, say assume a most comfortable position, and take an x-ray. And that's going to be your osteotomy angle, not what you see on the left. So it's going to be more correction, not less usually, so they stand with a relaxed suboccipital region. We avoid PSO when possible, so that we do a lot of these type 2 osteotomies posteriorly, where we're uncovering the nerve root completely and removing the superior and inferior articular process. Why? Well, when we looked at our results, we found the following. Number 1, we get more cervical lordosis correction if we do SPOs. This is really not surprising because we're not doing a lot of mid-cervical PSO, for example. PSO is really the workhorse for translational correction of the head, and we get better correction of the T1 slope minus cervical lordosis when we do this. However, we find that Neurological complications are a bit higher, especially when we do the osteotomies in the C7 or T1 region, doing 3-column osteotomies. This is linked to the amount of kyphosis correction. Also, we see higher surgical complication rates when we have kyphosis greater than 20 degrees or cervical SVA greater than 8 centimeters. Medical complications are greater when we do anterior-posterior surgery. So we try to avoid combined anterior-posterior surgery on patients that are frail, and now we try to do more all-posterior surgery on those patients. Here's a typical case where we tried to avoid a PSO in a semi-rigid deformity. You can see the kyphosis. This patient we applied a type 2 osteotomy to, and the key to this procedure to avoiding complications is removing this superior articular process. So after the osteotomy is mostly done, you have to reach under the lateral mass above with a curette and really dig out that superior articular process to get the superior articular process out, so you don't have foraminal compromise on closure. And then we close the SPOs by doing sequential head elevation and then slow reduction with cantilever technique, just like you would do for Schurman's kyphosis case. So we just creep our way down, starting in the cervical spine, working our way down. And we do always use pedicle screws now when we can for these types of corrections. Early on in our experience, we use lateral mass, but it doesn't work very well with cantilever type correction technique. So here's a case where we used pedicle screws and all type 2 osteotomies, all posterior. Also, using the pedicle screws enables you to really preserve a lot of that medial bone, and you can do a wide osteotomy without having to preserve the lateral mass for fusion. So it really is very, very helpful for cervical deformity. We use custom rods in really all of our cervical deformity cases now because the planning can be quite difficult. So we're doing this position of comfort. We're trying to build in some reciprocal change in the lumbar and the pelvis. And for this, we think the custom rods are probably going to be the most helpful. Here's a case where we used custom rods. Patient assumed a position of comfort. We planned him out. You can see his PJF, which was rigid, and then the planning that we did for him, and then his correction utilizing the custom rod that was connected to his main rod. A few words about the mechanics of execution. When we use custom rods, it's very important that we use a separate correction rod, so that if you have a custom-made rod made, that rod is showing you what your final correction should be. It does not build into it any ability to do a cantilever correction that's going to bend your rod and you're going to be deceived. So if you're using custom rods to try to get your cervical thoracic corrections just perfect, you have to use a correction rod to assist you with the closure. And this is just kind of making that point. You can see us, I'll just play this out just a little bit. We're going to do our closure of the PSO utilizing the correction rod, and then we would place our main rod that was templated for the patient on the contralateral side. Again, we don't use lateral mass screws. If we do, this is what happens if you cantilever these patients. I wish I could tell you that was a cadaver, that was a real case where we had pedicle screws on one side and lateral mass on the other, and we totally pulled those screws out. So we always use pedicle screws in these cases. Now for every cervical deformity, whether it's a type 1, 2, or 3 deformity, where we're staying in the upper thoracic, or whether we're going all the way to the thoracolumbar junction, we use all cervical pedicle screws now. This gives us tremendous power. You can even overpower anterior osteophytes and break the spine open using these. This was a case, a very severe mid-cervical kyphosis case, where we couldn't even get in to release her really from an anterior approach. And then we opened her up all from the back using pedicle screws, and then finally corrected her using PSOs in the lumbar spine as well. So this patient had very severe rigid deformity from an inflammatory arthritis, requiring multiple 3-column osteotomies. For cervical thoracic scoliosis, these are more rare. Again, we try to avoid PSO. Most of these cases can be done with type 2 osteotomy, like in this case with pedicle screws. Here you can see the deformity. We use pedicle screws for these cases. to place. And then to do the correction, after we've done all the release, you'll see we use this attachment, which I'll show you later in the talk. We'll just, after my partner gets all the reduction instruments on, we're just slowly going to move that head over to do the correction. So a lot of our correction forces are applied through head manipulation rather than through cantilever now. So that's been kind of an evolution. We're going to cantilever. We definitely use definitely use pedicle screws, but we also try to do more of the correction by just altering the head position, like in this case. For pedicle screws, we use navigation, and we do monitor our screws going in as well to make the insertion as safe as possible. We've not had any vertebral artery injury with subaxial pedicle screws, nor have we had to go back and take any out. But we do place them using navigation, and we do check them using O-arm conformation. The mechanics of execution you can see here. We use conical taps to do the decancellation. We use racks to stabilize the spine. And then many of these osteotomies for translational correction are done in the upper thoracic spine. So it's quite similar to thoracic VCR technique that you might already be familiar with. We use 2 attending surgeons. You can see we work simultaneously. And then we break the middle column using central impactor. And then we do the closure utilizing head manipulation. So again, my partner is watching the spinal cord here, and I'm going to lift up the head to do the correction. One advance we've had in recent years, and I don't have anything to do with this company, but we use the OSI attachment. It provides kind of controlled power steering for the head, and is very helpful for head manipulation for the correction. It's much safer than disconnecting somebody from a Mayfield or or in a Mayfield or in a Halo from the table completely, and we're trying to reattach them. It's very difficult. This is very easy to do the corrections. On the table, we use the back of the head to the thoracic apex. The table's level, the back of the head is level to the thoracic apex. It tells us we have a pretty good correction. And then we also look at our in construct correction C2 to the vertical angle to validate our corrections on the table. And we do long plate 2D films on the O-arm to make sure we have it correct. A couple cases and things we've learned. In mild deformities, if they do need a PSO, don't skimp just because you don't want to do it. You're not going to be happy unless you get them fully corrected. In this case, we did a PSO in her, even though she had a mild deformity and hardware malposition from her prior case. And this was in a case where we couldn't place pedicle screws. Her pedicles were too small, so we went back and filled her in from the front to make sure that we got her adequately grafted. In very severe cases, again, we don't skimp on the correction. This patient needed 2 PSOs in the thoracic spine and 1 in the lumbar to be fully corrected. We did 2 PSOs in 1 day in the thoracic spine and 1 in the lumbar to follow. So we did 3 3-column osteotomies for her final correction, and using 2 attending surgeons who are experienced in 3-column osteotomies. These are safe and reproducible procedures, but don't skimp just because you think that you can't do it. You can stage the case, you can use other surgeons. Patients are unhappy if they're not adequately corrected. Finally, I want to talk about complications just very briefly in a minute or two. Complication rates remain high. The biggest complication we see is junctional failure. This is still a problem for us, especially distally. It's 90% of these failures are distal failures, and some of these patients still require reoperation. Also, over the years, we've shifted the location of our PSOs lower. We really try to avoid C7 and T1 when at all possible, because at 1-year follow-up, patients that we did at C7, T1 that developed C8 weakness, about 75% of them were improved, but 25% were still weak, and they had hand atrophy, and that's a much worse deficit than getting quadricep atrophy after a lumbar PSO. Here's our series as it stands. This was 151 cases. You can see the locations of our osteotomies. We really try to shift these down in the upper thoracic spine, as you can see reflected in our numbers. Here's our distal failure case example. Again, big problem even with cement. Many of these patients end up extended down to the pelvis. Distal failure is the main type of failure that we see. What are we doing? Well, many of them we have to extend to the pelvis. We've utilized some ligament augmentation to try to prevent this distally, as well as something we're looking at, but we really don't have a perfect solution as of yet. And then finally, for rod fracture, we use this Z-rod configuration now to try to prevent rod fracture. It does a couple things. It gives rotational stability, it prevents rod fracture, and it provides a dorsal covering to the spinal cord. So I'll finish there. Sorry if I ran over. Please feel free to cut me off earlier. And thank you all very much for your attention. Great.
So I'll ask Lennell if you would just show us the solution. Do we have Professor Ames online? Can you see?
I'm online, yes.
We do. Okay, if we can put him up and... Good morning, Chris. Can you hear me?
I can. Good afternoon.
Yes. Thank you for taking time of your busy schedule. You have the distinction of keeping people here when many times they've already left. So well done. A couple of really great talks. I don't know if you can see, but Lennell Lutchman, my colleague, will just present a case of ACD, and then we'll open up to questions, Chris. Thank you.
Sure.
Great. So it's a pleasure to, in a sort of virtual sense, share the stage with Dr. Ames. Much of the literature pertaining to this type of problem has been borne out by work by the ISSG. One of the things that comes across in the first talk is the importance of looking at the C2 to C7 SVA and looking at the cervical lordosis. So those measurements are shown here. The lordosis measured from the inferior end plate of C2 and the inferior end plate of C7, and the C2 to C7 SVA measured from the center of those vertebrae. And it's interesting to hear about the comfortable position. We all know that patients do make a conscious effort to stand up straight, and when you ask them to relax into their normal position, it unveils quite a marked deformity. It's important when they have their radiographs as well that we tell the radiographers that that's the position that we want the patients to be standing in their comfortable position. I've tried to measure those parameters on these x-rays. So the C2 to C7 SVA is about 7 centimeters, and the lordosis is minus 37. So this is a kyphotic neck with the apex base and the mid-cervical spine. I don't have, again, I apologize for not having the full-length radiographs to show us the C2 to the global balance. But this appeared to be mainly a deformity in the cervical region. Dr. Ames showed us this before, and we find this very helpful in decision-making. One might not be able to answer all the questions presented by the classification, but we try to. This seminal work from 2015 refers to the ISSG classification of cervical spine deformity. So this is a cervical deformity in the descriptor. The C2, C7 SVA is a grade 1 because it's 7 centimeters. I don't have the horizontal gaze measurement. The lordosis is minus 30, we said, and this lady's myelopathy grade was grade 1. In the absence of the global films, I can't really comment on the Schwab classification. We find this helpful, and it's worth spending sort of 1 minute looking at it. It's pretty self-evident and logical, and it comes from this work by Han from 2014. if the deformity, looking at the top pathway, is fixed, i.e. not passively correctable, then the thing's ankylosed or not ankylosed. If it's ankylosed, one requires an osteotomy, and if it's not, release might suffice. The lower part of the graph table shows that if the deformity is passively correctable, the correction might be more easily achieved and might not require an osteotomy. And that just sort of stands up to common sense, really. So the strategy we adopted here we thought about the possibility of traction helping. We knew that 3-4 needed to be decompressed. That's a level of a myelopathy. We've demonstrated on CT that C5, 6, and C6, 7 are fused anteriorly, but the disc space still looks to be preserved. So we felt that by releasing the anterior osteophytes and doing an anterior column release, we should be able to achieve a reasonable correction. We contemplated whether or not we would do a single stage procedure or whether or not we would stage it with a second posterior operation. Based on the photographs that I showed you, by a show of hands, who would try traction in this case? That's interesting. It's quite a lot of people, and I have to say I was very skeptical when Andy said he was going to try. Based on the flexion extension radiographs, one would not anticipate much improvement, but bear in mind the patient's in pain when they're trying to do flexion extension, and with gentle traction for 48 hours prior to the procedure, I was impressed and surprised by how much of a correction could be achieved passively. And now you think you're in with a fighting chance, don't you? You can get into the front of the spine, you can see that you can treat the myelopathic level, and you can release the 2 adjacent levels below. And that's what Andrew did. This is a day 3 post-operative X-ray following a first stage procedure. Anterior, not very simple, but anterior releases, clearing the disc spaces, and achieving a relatively good correction. Who thinks that, by a show of hands, who thinks that would suffice as an attempt to decompress and correct it? Who thinks that's all we need to do? By a show of hands, if this is all you would do, you'd stop at this stage. A minority. And by show of hands, who would do a posterior procedure as well to stabilize the spine? Considerably more people. By day 6, she's up and about, and we'd intended to do a posterior procedure. I don't think we would have the confidence to feel that that would be sufficient. And the patient had a posterior procedure as well. I think what we find is that both in lumbar degenerative deformity and in cervical deformity, we quite like staging them now. An interval X-ray taken between stages often gives you useful information as to how far distally one needs to fuse, and also helps considerably with your second stage planning. So our preference is really to stage these procedures. And Andrew also, based on Dr. Ames's comments about distal junctional kyphosis, elected to prophylactically do some vertebroplasty at the 2 subjacent levels. And this is an 18-month follow-up X-ray. It's important to say that, as anticipated, her mild myelopathy has not progressed. Her spinal alignment clinically and radiologically is much improved, but her neck pain is still a significant problem. And we were careful in our counseling of her to express our reservations about being able to correct her pain with surgery. I think that's really important. So the considerations here were a head drop deformity in a patient with myelopathy. I think the presence of the myelopathy is actually helpful because it means that you have a very good mandate for surgery. The big question then becomes, ought one to try to address the deformity? I was surprised by the benefit of traction here, and it's a good lesson learned for me. We tried our best to restore her sagittal balance using a stage procedure, and we tried here to anticipate and mitigate distal junctional failure. On the scale of things, this is not a particularly complex case based on the stuff that Dr. Ames has been showing us, but I think it highlights quite well the strategy of Where are your tethers? What's the ambition of the surgery? How are you going to plan it, and how are you going to execute it? Pass it back to Dr. Ames.
Thanks so much. Can we put Dr. Ames out? So, Chris, we are running a little bit late, but given the effort that Professor Ames has put in, I'd invite questions related to his really two great talks. Do you have any questions? Chris, whilst we're waiting for, I don't know if you heard Lenel's presentation, but I was impressed by how well you were able to overpower the osteophytes anteriorly, and you showed a very dramatic case where you opened up. How far can you take that? You know, in other words, in the absence of myelopathy, how many levels that are sort of semi-ankylosed would you have confidence that you could actually break them all from the back?
It's often a bit difficult to know, to be honest. A little bit of bridging osteophyte with otherwise good quality bone and the ability to place large screws, which is the other part of the equation, you can usually mobilize. So if we see the pedicles are of decent size and it's just kind of a bridging osteophyte anteriorly, that's something we feel like we can probably overpower. Obviously, if the whole disc is fused, that's a very different matter. But it's also done in the setting, obviously, of a type 2 osteotomy. So a little bit of bridging osteophyte, big pedicles, and a type 2 osteotomy, often that can be immobilized more and more in my experience, all from a posterior approach. The downside, though, is that there is the risk, if the disc is collapsed, of foraminal compromise. So going anteriorly, and like in this case, and elevating the space and creating more foraminal room prior to the posterior closure is a really nice way to go. And we often use, just like in this case, we use traction to try to figure out exactly what the mobility is going to be. If you don't get mobility and traction, that to us is looking like a 540 case, for example, where you have to go in and mobilize the joints and then go anteriorly. The traction in this case really showed quite nicely that you could just go anterior-posterior. And I totally agree that you couldn't do this purely anteriorly. If you were going to try, you'd have to place a segmental plate because the infixed interbody cages will definitely collapse back down into kyphosis just with an all anterior approach. So if you're going to try it, you definitely need a plate, but in my experience, it's much better to go posteriorly. So I also just wanted to comment, beautiful case, exactly what our thinking would have been on that case, and a really nice result.
Adrian Gardner from...
So Adrian Gardner, Birmingham. I just wondered if you could comment slightly on the health economic benefits of cervical deformity surgery. It's big surgery, and like in adult deformity surgery, there's always a question about whether it's worth it for the cost that you put into it. I suspect it is for adult deformity surgery, but I'm interested from your thoughts on the cervical spine as well.
It's a great question, especially with our aging population around the world and these becoming more common. As I mentioned in my first talk, these patients are extremely disabled by EQ5D, on the order of patients that have impaired vision, partial paralysis, and severe obstructive pulmonary disease. So they are extremely impaired patients. There's a further distinction, though, of the cervical deformity patient, and it's that they are more frail typically than the severe adult deformity patient. There's something physiologic going on with them where their complication rates are higher, their sarcopenia is greater, their comorbidities are often more burdensome and more significant. So for sure, these patients have higher complication rates and they are more frail, and they're going to cost the healthcare system usually more per surgery. So they are definitely very disabled. We need to do a lot more work in the cost effectiveness. So we've established that they're very disabled. We've established that they're more frail, that they have higher complication rates, but something our group needs to do a better job on, and the registries around the world, is showing that actually the surgical result is cost effective. Probably it's going to be very similar to the lumbar spine, where it's only going to be cost effective if we can keep them from being revised. Lumbar deformity, thoracolumbar deformity, for example, is only cost effective if the patients are not revised out to 10 years. and the ICER begins to approach about 75, 80,000, which is still a little high for the incremental cost effectiveness ratio, but starts to get it into the cost effectiveness zone. I feel like these cervical deformity cases are still probably very marginal, even out to 5 to 10 years.
And Chris, just to follow up on that, given the complication rate, which you've been very honest and transparent about, do those complications meaningfully impact on the outcome scores running out to 2 years and beyond?
You know, things like distal junctional failure have more of a temporary impact because they can be extended to the pelvis, and they end up, at least structurally and functional-wise, doing reasonably well. The problem is that, as I mentioned, if you do a thoracolumbar PSO and they have quadricep weakness, usually that's not a problem beyond 6 months or so. It improves and the patient's ambulatory and they're straighter, so they're happy. But if you take a cervical thoracic deformity case and they have dominant hand atrophy at 1 year, that's still an unhappy patient. So the neurological complications are quite burdensome. There's also data from the European Spine Study Group that shows that if you reoperate on a complex deformity patient, whether these are thoracolumbar patients, you do limit ultimately their health-related quality of life improvement. So I think we have a neurological deficit rate problem at the C7T1 level, and we also have a reoperation rate problem on these cervical deformity patients that's still impactful.
Any further questions? Well, Chris, we're running a little bit behind, but on behalf of us all here in BritSpine, we'd like to thank you for a couple of really wonderful lectures and for giving us the benefit of your expertise and huge research endeavors. So on behalf of us all, we'd like to thank you in the usual way. Thank you.
Thank you so much. It was a real honor. Have a good rest of your meeting.
Okay, take care, Chris, and many thanks to you.
Bye,
and
guys.
on that, I'll hand over to our chair of UKSSB, Sachin Ahuja. Thank you very much.